So I'll go ahead and start them off with a nasal cannula. First things first, I'm gonna go ahead and get my oxygen bottle squared away. I know this is oxygen because it's green on the top. I know it's oxygen because it has a yellow sticker that says oxygen on it. It also has a couple letters here that says USP, stands for US Pharmacopoeia, so I know it's medical grade oxygen. I'm gonna go ahead and make sure my oxygen bottle is safe to use, no damages, dinks, cracks, anything like that on the bottom and top. Looks good. I will take my O2 key and turn it to the left to disperse some air. Because sound effects are very important. Go ahead, now inspect my regulator. Put my oxygen bottle down to keep it safe. This is my regulator right here. The regulator has a couple of components. I have these two prongs. They are called the PIS system, or Pin Index Safety System. Next to it should be a rubber gasket, which is missing right now, so technically this would be out of service. Rubber gasket is also called an O-ring. I also have my pressure gauge. My pressure gauge is from 0 to 3,000 psi, but I know that my bottle contains 2,000 psi to make it full. I will change my bottle out at 500 when it's off a patient and 250 when it's on a patient. Off to the side here, I have my flow meter, which goes from 0 to 25 liters per minute. And I think that's it. So I'm going to go ahead and put it on. I make sure that the prongs go inside the holes. I go hand tight. I make sure that this is set to off or 0. Take my O2 key. I'm gonna go ahead and turn all the way to the left, and I'm gonna check for any leaks. I'm listening, I don't hear anything. I'm gonna go all the way to the left. Once I go all the way left, I do a quarter circle back. Okay, now my oxygen bottle is ready to go. Take my nasal cannula. I'm gonna go ahead and connect. My nasal cannula goes from, okay, just pretend like there's actually tubing here. This tubing goes into my nipple or tree located on top of the regulator. 1 to 6 liters per minute, 24 to 44% of oxygen is being delivered. Connect that, boom. I'll go ahead and start off with 4 liters. Okay. Go up to my patient, make sure the prongs they're facing the correct way. Sir and ma'am, you're gonna feel a little tickle in your nose. Into the nose, around the ears, chin strap, good. And that's it. This right here is my capnography. It goes inside the monitor, or the LifePak 15 that you'll see in your clinicals. It reads the amount of carbon dioxide that's being exhaled. All right, my patient is expressing more signs of distress. Pulse oximetry is dropping below 94% of oxygen. Maybe they're having retractions, maybe they're having trap position. So I'll go ahead and upgrade it to non-breather. I'm gonna go ahead and set this up first before I take my patient off oxygen. Normally, this would be a strap that actually works. It goes like this, and I have a metal piece that goes around the nose. This is set to 10 to 15 liters per minute. Connecting again to my nipple area. It can deliver up to 90 to 95% of oxygen. Let's go ahead and start off with 10. I would then I can remove this or keep it on them, depends on if this is measuring capnography or not. I would go over the patient's face like this. Before putting it on, I'll put my finger, my glove finger, or I would put my plastic over that one-way valve and fill this reservoir bag first. Once this bag is full, I'll go ahead and put it around the patient's face, like that. Sir, ma'am, try to take some deep breaths with that. This is gonna help. This is the highest oxygen delivery I can give you. This will save your life. You know, stuff like that to make them feel comfortable. From here, let's say my patient eventually starts becoming lethargic, or they start to change responsiveness on me. I want to check how they're doing. So I'll say, let's call him Bob. Bob, are you good? He didn't respond to verbal stimuli. Bob, I'm gonna try my sternal rub or flicking the eyelids. No response. My patient is now considered unconscious. So I'll go ahead and check for a carotid pulse here, and look, listen, and feel for any breathing for no more than 5 to 10 seconds. I feel a strong pulse, but the patient is not really breathing that well, inadequately irregular, maybe lower than 10 breaths a minute. I'll go ahead and set up my BVM because I know that I need to breathe for this patient now. But I'll keep everything on him for the meantime. So I'll go ahead and have 30 seconds to set up my BVM. BVM delivers 15 to 25 liters per minute, 100% of oxygen. Okay, I'll go ahead, disconnect. Set it up to 25 liters per minute, put it down. Take all this off them so I can have a good seal. I'm gonna go ahead and do a head tilt chin lift. Look inside the airway. Looking for any blood, mucus, teeth, dentures, vomit. I don't see anything. I'm gonna do the EC clamp technique, nose over the mouth, around the jaw. Take my dominant hand on the mask and breathe. Squeeze the bag over 1 second every 5 to 6 seconds, looking for chest rise in 10 to 12 a minute. So 1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi, 5 Mississippi. All right, I start to feel some resistance. 3 reasons why, or 4 reasons actually. It could be maybe there's gastric distension, maybe my seal could be bad, maybe my airway's not open. There could be a obstruction like vomit or the tongue, or the patient's starting to breathe on their own. But right now I can tell that it could just be me, so I'm gonna go ahead and readjust first. Head tilt chin lift once again, open the airway, double check there's nothing in there, and try my seal once more. All right, I still feel resistance, so it could be the tongue, so I'll try to improve it by using an OPA. Okay, these are my 3 sizes. OPA is an oropharyngeal adjunct. The contraindications are consciousness, gag reflex, and oral trauma. Measure from the corner of the mouth to the ear. Okay, the size is good. I'm gonna come in from a 90-degree angle at the corner of the mouth. I'm gonna go in and insert as I rotate 90 degrees, capturing the tongue and making sure that the OPA is flushed over the lips. Patient starts to gag, so I'm gonna go ahead and remove it as I prepare and remove it anatomically and go into the patient's left side. The reason why I go on the patient's left side, hopefully your patient moves along. I go on the left side because the stomach is on the left side and I'm compressing it and therefore forcing vomit to come out, preventing it from coming back in. Preventing aspiration is the key word. All right, so while this is happening, I could prepare my suction. Step 1 is turning it on. Step 2 is checking my tubing, making sure there's no kinks in the line, connected to a yanker tip, a hard, rigid tip. Making sure this is good, my cap is good, my lid is on. I set my pressure to 300 millimeters of mercury for an adult or 150 for a child. Okay, checking my suction on a gloved hand. Feels good. Go in here, open the airway. Go in with my finger off the hole. Not suctioning, going as far as I can see. So my finger on the hole. Start to suction in circular motions for no more than 15 seconds. 10 seconds for a child and 5 seconds for an infant. Okay, turn this off. The airway is now clear. Suctioning causes hypoxia, so I'll go ahead and start pre-oxygenating the patient once more. Head tilt, chin lift, of course. EC clamp technique. I'm going to squeeze the bag. Oh God, too good ventilations. I will squeeze the bag over 1 second every 5 to 6 seconds, 10 to 12 a minute, looking for equal chest rise and fall. I will do this for another 2 minutes, or as long as it takes to get the patient to a pulse oximetry of 94 to 99%. Let's say it's been that long. All right, OPA did not work because the patient has a gag reflex, so I'll go ahead and do an NPA. NPA is a nasopharyngeal adjunct. Contraindications are nasal trauma or facial trauma or signs of head injury. Signs of head injury could be maybe patient has unequal pupils, maybe they have actual injury to the head, maybe they have CSF, cerebrospinal fluid, or blood coming out of the ears or the nose. Maybe they have bruising around the eyes called raccoon eyes, or they have bruising around behind the ears called battle signs. All right, I'll go ahead and make sure I measure from the nose to the corner of the ear. This one seems too small. Okay, once I found the right size, I'll go ahead and I will lube it up with water-based soluble lube, or I can go ahead and use the patient's spit if I need to. I will insert into the right nostril, because usually the right nostril is bigger. Either or is fine. I'll take my bevel to the septum, and I will insert and rotate as I go in. I think this guy's nose is broken. Okay, there we go. I can put 2 in if I need to. And I'll go ahead and I'll continue my respirations, CEC clamp technique. Ventilating over 1 second, every 5 to 6 seconds. 10 and 12 a minute, looking for a chest rise and fall. And scene. Thank you.
Good job.